Welcome to the Tinderbox Podcast, where we ignite change and fuel justice. I'm your host, Mishka Russell. There's a question that lives at the intersection of the heart of our mission. It is, who gets to age with dignity? Who gets to die with peace? And who is left to suffer in silence? Today, we're confronting those questions head on because when we talk about health equity, we see it show up in the access to care. And we also talk about when persons might have a terminal diagnosis that might need different access to care. The data tells us in a May 2024 research article that was published in the Journal of American Geriatric Society that found that Black patients with serious illness are significantly less likely to have advanced care planning discussion with their physician and less likely to be offered a conversation. This is a failure of the system and a failure of trust. That's why we are so honored to bring you a conversation with a physician who has spent her career at the intersection of aging, serious illness, and health justice. She's a clinician, an educator, and a fierce advocate for making end-of-life conversation as sacred and dignified as the beginning of life. I want to give you a brief intro to Dr. Shelley Williams' bio before we begin our conversation. Dr. Williams is an associate professor of medicine at the University of Chicago, where she practices both geriatric and palliative medicine. Dr. Williams' clinical focus is improving care of older adults living with dementia and under-resourced communities on Chicago's South Side. She is a dedicated educator and clinician and advocate, and a community-based researcher who focuses her work on addressing dementia education and care access disparities for patients of color and their care partners. As a clinician, she provides patient-centered care for those that she sees in all care settings, inpatient, clinical, and long-term care facilities, and home settings. Her scholarly focus is dementia education, awareness, and resources through work on committees and leadership appointments, including supporting healthy aging resources and education, which is the SHARE network. And in addition, Dr. Williams developed and launched 2 initiative education and intervention models that help improve dementia education, access to care, and decision to support that care. Those are the Dementia Resource Champions, which is a training for faith leaders to identify signs of dementia within their congregations and connects them to resources for optimizing that care in support of the community. And Centering Our Values, which is a dementia care decision support and education resource for caregivers to support their values in supporting that care. She is a member of the University of Chicago's Diversity and Inclusion and Physician Assistance Committees, and she's chair of the American Academy of Hospice and Palliative Medicine Black Professionals, Patients and Families Forum, and co-director of Cultivating Health and Aging Researchers by integrating science, medicine, and aging. This program is for underrepresented and undergraduates and mentors in the Tinswell Emerging Leaders of Aging program. Please join me in welcoming Dr. Shelley Williams to the Tinderbox Podcast community. Welcome, Dr. Williams.
Thank you, Mishka. It's a pleasure to be here. And I was just struck in your introduction talking about change and the word justice.
Yeah.
And that's a huge part of the reason why I wanted to be on today. And I really thank you for inviting me. I would love to be able to change the African American community's perception of what hospice and palliative medicine is, and in creating that change, be able to create justice as far as access to those resources that are vital to people who are dealing with serious illness.
Absolutely. And I think a great place for us to start this morning is to offer a layman's definition for palliative medicine so that we can get that information out to the community, and then let's progress in the conversation from there.
Sure. And Stepford three different things. So I practice both geriatrics as well as palliative care. And geriatrics is a form of medicine where we focus on aging and trying to create health in older adults, whether they're dealing with hypertension or diabetes or osteoarthritis. Those are conditions, especially osteoporosis and osteoarthritis, are conditions that are very common in aging. And a traditional internist or a family medicine doctor may not be as well aware of how to optimize the care of someone dealing with those diseases that are unique to aging. So that's geriatrics. Mm-hmm. But when I think of my role and my focus in palliative medicine, it's the field of medicine that's focused on caring for people who have serious illness. That serious illness might be cancer, it might be heart disease, it might even be diabetes, which can be a serious illness.
Yeah.
And palliative medicine is the care of those individuals living with that serious illness from the beginning of the illness all the way through the end of it. We deal with in palliative medicine, how do you treat the symptoms of that illness? But we also deal with how do you make decisions about what care makes the most sense for you living with that illness? And I want to focus on that term, living with that illness.
Yes, absolutely.
And then hospice is a very, very small part of palliative medicine. Hospice is a focus of serious illness in someone who has potentially a less than 6 month prognosis,
Okay.
less than 6 months of life expectancy.
Mm-hmm.
And the reason why doctors oftentimes will recommend things like hospice is because when people have a serious illness where they have limited life expectancy, they oftentimes will have escalation in symptoms. They may have more shortness of breath or more pain that needs more aggressive treatment and a specialist who knows how to handle that treatment. And they may also have important decisions at that time too, where they need a little bit more help and guidance with those decisions.
Yeah.
So palliative care and hospice in some ways are related, but they are very different. The hospice is usually when people are more limited in life expectancy,
Mm-hmm.
whereas palliative care is all throughout the entire course of serious illness.
And thank you for separating that and giving that distinction. I think that language sometimes gets confused, maybe when people are presented with it in the hospital setting, or maybe they've never heard the term palliative medicine before, but they have had some cursory understanding of hospice because someone in their family has was offered that, or that conversation might have come up at the end of life, or they might have had a friend or someone. And I think one of the things that I want to get your perspective on is how hospice, that term, that knowledge, that understanding has, we're going to use the a dirty connotation, a really, people have a really visceral reaction when they might hear that term in the hospital. And so tell me, in your work, how do you bridge that divide of, I'm going to use the word trust or understanding of that, and offer clarity about what palliative medicine is, and then again moving into hospice care.
I think the important part is really coming from a point of openness with the patient and families, asking them, have they heard that term before?
Mhm.
Palliative care, or have they heard that term before? Hospice, and asking them what their perception of it is and why they have that perception. What I hear a lot of the times from African American families is, you're talking about hospice? Am I dying?
Yeah.
Am I going to die tomorrow?
Yeah.
Because when my brother enrolled in hospice, he died within 2 days. Or when my cousin enrolled in hospice, they stopped doing this for them. They stopped doing that. There's so many myths that if you don't sit down with an individual
Hmm.
and get to know them and get to know their understanding, you're doing a disservice to that patient and family. And they are not getting equitable care.
And with those conversations, the work of it, because we are dealing with, again, cultural dynamics as well in those conversations, right? How is that cultural humility, cultural sensitivity, that training, that understanding that certain words, certain phraseology, certain belief systems play a huge part in that with persons, and how clinicians can bridge that gap of understanding of cultural significance and medical advice and find some congruence between the two.
I think it again goes back to communication and making sure everyone's on the same page. So I think the first step to bridging the gap is having an understanding of where the patient and the family are, asking them permission to talk a little bit about the reality
Yeah,
of what these services are and what these services can provide
yeah,
as far as the needs that you're hearing that they as a family have. And then talking about the elephant in the room. Mistrust in the African American community is real.
it's real. Yeah,
Everything from slavery to even at this present time, disparities as far as pain control in African Americans versus Caucasian,
yeah,
access to services like palliative medicine and hospice, um, both in both in the area of where the person lives, but then also can they, as an African American, socioeconomically afford for a loved one who's an informal caregiver to take off to be at home and care for someone as they enroll in services like palliative medicine or hospice. So I think if we don't get past the communication problems and talking about the trust barriers, then a lot of people are going to opt. I don't want that service.
yeah.
That service is going to take things away from me and my family, or that service is going to accelerate my loved one going from life to death. You and I know the reality that's not true.
Yeah.
But
Yeah.
unless we take the time with patients and families to overcome those barriers, we as health professionals really are doing a disservice.
Yeah. And I love the word that you use, getting permission. In my work, so, again, some of the community know that I am a board certified chaplain, and we get called in. We do a lot of work with medicine and journeying with you all and patients. And I liken that word of permission, of reverence to their voice, to their story, to their humanity, of being curious about where they are so that we can, I always use the word journey with them through this decision making process and understanding what their desires, what their wishes are, and how we can support them in that with medical information. So, with that, we talked about, some myths that are in our community and some of the different disparities again that run the gamut with the African American community and medicine. And so in your research, in your training other clinicians, in your position that you have, what are some ways that you have been able to move the needle on some of that and invite other allies and advocates to be curious about expanding their knowledge of how to journey with persons who present differently from them when they're having these particular kinds of conversations?
I think a key important component is to look at communities, but then also look at the individual. If I look at the African American community as a whole,
Mhm.
the church has always been a refuge, a place of education, and a place of trust. So definitely involving the faith community in a lot of the messaging and education is really important. And then also looking at African Americans as individuals. Not everybody has a faith base.
Not everyone
So talking to the individual and trying to get a sense for who do you trust?
Mhm.
Why do you trust that particular person or that particular perception of hospice and palliative medicine? What are some of your needs? And how can we maybe bridge those needs? Sometimes when I'm having a discussion about what hospice is, I will, before I ask knowledge of hospice and palliative medicine, just talk about what the patients are experiencing at home, what some of their needs are, and then talk about services that can be provided in the home, like assistance with eating or assistance with getting medications for pain that are delivered directly to your home. A nurse coming on at least a weekly basis, a doctor coming and helping to monitor your symptoms along with the nurse, having access to a chaplain to come to your home, or social worker to help your family do FMLA paperwork, and then asking them, would these services be helpful? And then talking through those services can be provided free of charge through Medicare as a part of hospice benefit, and then talking through some of those myths that maybe have helped. I think it's really important to spend the time getting to know and getting to build trust with patients and families.
Yeah, and that is huge because, journeying with caring for persons who have serious illness and being a caregiver, there can be a sense of isolation, like where do I start? What do I do? It's overwhelming, all the different things that people have to navigate in the midst of all of their things that they're dealing with in their own daily lives. And to know that they can partner with the medical side of this social work to get this information to help them with, like you said, teaching and education and caring for individuals and paperwork and all of those different types of things. I'm glad that you lifted that up because that's one of those nuggets of information I think that's not out there enough to offer comfort to our community that there is aid. There is aid.
Yeah. You make me think of the famous saying, it takes a village to raise a child.
Right.
It takes a village to help someone live well.
Yeah.
And hospice and palliative medicine doesn't have to be about dying. It really is about making every day count despite the serious illness that you're living with.
Yeah.
And making every day count is not just about the person living with the illness, it's everybody who's around them who's experiencing that illness too. And it really does take a village. It can't just be the doctor and the nurse. You need that social worker sometimes to get equipment in the home or to do counseling, one-on-one with the patient and one-on-one with that daughter who just doesn't know how to get through this. Or you need that chaplain to do prayer or to do legacy building, talking about what are the things you want to leave those great grandchildren who you may not be able to be there for in 10 years.
Yeah. And I love that, again, in your work and in your education, that you've been intentional about as you said, the foundation of where a lot of trust and understanding comes in our community, which is from our churches. Even though, again, there are persons that don't have a faith foundation, and that's fine. But knowing historically that has been an anchor in our community for trusting in sacredness and safety. And so tell me a little bit about the program that you have, that you've joined with clergy. What are some of the I guess, the biggest questions that have come from that context, or aha moments maybe that persons did not know about the work that you do and how palliative medicine and hospice are, again, as I'm going to use your words, are about living, still about living. Yeah.
Yeah. So the program you're referring to is called the Dementia Resource Champions, and it really was a labor of love to try to provide education, but also resource access to church leaders who are oftentimes seeing their older congregants dealing with signs and symptoms of dementia, or the sons and daughters trying to navigate through how do I help and support mom or dad. And a big part of that training is not just educating about dementia, but educating about all of the different resources that are available for care and support for people living with dementia. And definitely palliative medicine and hospice is a key resource that I think a lot of families don't realize is available to them, to help with the day-to-day care, but also even to help with planning for the future. We know that dementia is a serious illness that over time starts to diminish our ability to communicate, or our ability to eat, or our ability to walk. And as many of those abilities are lost, family members are stepping in to help and support with those different tasks, but they're also stepping in to make a lot of serious choices about how does my loved one live, and when the time comes, how do they go from life to death. So it's important, even with that disease process, to refer patients to services like hospice to support that loved one. Could you imagine? It's something that I dealt with within my own family. I'm the youngest of six children, and we dealt with our mom, living and dying with complications of dementia over an 8-year period. And it was not easy.
Yeah.
It was not easy. But, those are some of the services that provided care and sanity
That
to
works.
us.
Yeah, because you can feel like, my gosh, what's going on, right? That am I going insane with all of these different things that are just like a deluge on people, and not really knowing, because we haven't had those conversations. We've not sat and asked those
Yeah.
questions, right?
Yeah.
Um,
And that's what's it really hurts my heart, sometimes when I think about families that are saying no to this resource
Yeah.
that could truly make a difference in the way that they experience their loved one, and that their loved one experiences them,
Yeah.
by having that guide through the journey.
Yeah. Yeah, absolutely. And I love how you just phrased that again, them experiencing their loved one, and their loved one being able to experience them, and understanding that part of their identity is still there. It's just challenged because of whatever chronic illness or serious illness that is going on. And to be able to, I always liken it to an act of love, of having the conversation while we are still. We have our cognitive ability to say what we want, say what our desires are, say what our wishes are, and then find that person that will agree with those wishes and see them through for us. Definitely. Yeah. It's such tender and sacred work. And I guess my curiosity also is, how did you come into this specialization, as your profession, as your career, as your life's work? What was that impetus for you that drew you towards this type of medicine?
Well, I knew I wanted to do geriatrics very early in my medical school training.
Okay.
I initially started out in pediatrics, but but after working with a family practitioner in medical school who specialized in geriatrics, I was like, that's for me. That's so interesting. Learn so much from your patients every day, and you feel like a detective. You're learning, like that this person is falling because they have a urinary tract infection or because the dose of the antihypertensive is too high.
Yeah.
That's something that may not be so evident to other providers that don't practice geriatrics. But what I found after I finished my geriatric fellowship was, as interesting as that was, I was seeing a lot of patients who had serious illnesses, whether it was heart disease or kidney disease. And I was having a lot of these complex conversations about what's next in this disease trajectory and how do I want to live my best with this disease and what are the things that I want to focus on when this disease gives me little time.
Yeah.
And I felt in my geriatric training, I did not have enough training for it. So that's when I started getting additional training in palliative medicine and hospice and went and sat for my boards in specialty, did a lot more inpatient consults for palliative medicine. And I find I'm probably like 50-50 with the two disciplines.
Okay.
I'm 50% geri, 50% palliative medicine. But I just love, it's a privilege to be able to be a support and a guide for patients and families. It's a privilege to get to know who they are and what they honor and treasure most, and try to be able to provide resources to make sure that they can still see those things that they honor and treasure most.
Absolutely. And to have an African American female be represented in palliative medicine and hospice care, and geriatrics, again, as the cultural dynamic of seeing people that are representative of who we are in the medical field and in medical specialties, comfort, a different level of comfort, I guess I'll put it that way, a different level of comfort.
I think
Go ahead.
No, I think it definitely does to see someone that feels familiar.
Yeah.
But it doesn't just have to be the physician. I wish we could truly expand the workforce of advanced practice nurses, of death doulas,
Yeah.
nurses, CNAs that truly have a passion and a focus for the geriatric population or for those dealing with serious illness. Because this is an honor.
Yeah.
It really is. And what I am seeing in geriatrics, what I'm seeing in palliative medicine, are the same things that everybody's going to see at some point in their lives with a parent or a loved one or themselves. And, to be able to guide someone else through, it just really gives you perspective for your own life too.
Yeah, I love that. Yeah, yeah, we're all going to be confronted with end of life decisions or complex decisions that center around our medical care, our well-being, our wellness, and to have I guess I'm going to say, the wherewithal or to not be afraid to have those conversations, right? To have trusted partners along this journey where you can have those conversations and know that the information is something that can be trusted and it can be tailored. I'm going to use that particular word to their care need, which we don't hear a lot about that with medicine. We don't hear tailoring a lot. We feel like it's a one size fit all, unfortunately, sometimes.
It's not. It's not. When we approach it that way, that's when we get a lot of pushback,
Yeah.
a lot of misinformation. And unfortunately, I think that's why we're in the trouble we are now with so many people pushing back against that term palliative medicine and hospice.
Yeah.
Because people are making assumptions instead of coming together and getting to a point of knowledge of one another.
Yeah, absolutely. And so, what are some things that you might be able to share with our community that are on the front line of research in palliative medicine and in hospice? You also threw out a term there. I knew what it meant, but our audience may not. Death doula, and how some of that is some research that is on the impetus on the front line of these service lines.
I think the biggest, the disparity and acceptance of services like hospice and palliative medicine.
Mhm.
If we look at most of the research, less than 10% of hospice enrollees are African American,
Wow.
whereas about 70% are Caucasian Americans. And a big part of what we're seeing in most of the research literature is a big barrier is the communication aspect.
Mhm.
And another huge barrier is just that socioeconomic aspect. So those are two big areas that research is focusing on right now. How do we improve that communication? One of the assumptions is getting providers that look like the patients they're caring for. And even though that is, one way to improve
Mhm.
some of the access, I think we have to think a little bit broader.
Yeah.
So that's why, a lot of focus within the faith community is coming up. A lot of focus within different facilities where patients may get care, like nursing facilities, is coming up, because you can't just rely upon having the provider and the patient be, similar. As far as socioeconomic status, unfortunately, that's something that we're still dealing with.
Yeah.
As as a systemic racism factor and a factor of even slavery,
Mhm.
the disproportionate access to income and wealth. So I think one of the ways to overcome some of those barriers is making sure that we put in the referrals and that we're clear with individual patients and families about what this resource is and really talk about those myths that exist.
I I love that focus on all the different intersections of people's lives to make sure that they are aware in a time where miscommunication and disinformation runs rampant, unfortunately, and causes people to, again, we've used the word a lot of times, fearful, and not want to have conversations or not even want to go to medical institutions because of how they are fearful of how they will be treated or how they might be perceived or not valuing their voice or their experience in those contexts.
Well, the reality is a lot of individuals, if they were enrolling earlier
Mhm.
in hospice
Mm.
services, you and your loved ones could stay at home more as opposed to in and out of hospitals
Yeah.
with people who are unfamiliar with you, unfamiliar with what it takes to make you feel comfortable. You could have services coming to your home. And a lot of people actually survive longer and do better
Yeah.
enrolling at hospice earlier instead of waiting until they get to a point of time where the symptoms are escalating so high that hospice is the only resource that can provide care.
Yeah.
If everyone could hear that message, the earlier
Yeah.
you get hospice services, the earlier you get palliative care services, the better you do. I think we would see a lot of those disparities decreasing. And we would see a lot of people living longer and better in their homes.
I love that. To again put that out there. We've got it on the recording. It's going to go out into social media. Again, is welcoming people to get to these services sooner so that our loved ones can live in dignity and live in comfort as they do journey towards end of life, and being able to be surrounded by those that they love, and know that they are cared for, and that the ones that are caring for them are being cared for as well by having resources, trusted voices, and being in a place that's familiar. I think that is one of
Yes.
the most important things, right? Being in a place that's familiar.
And I'm going to get in trouble with you. I forgot to define death doula.
That's okay. We can wrap back around. That's yes. Go ahead. Go ahead.
So I was thinking of death doula as an individual who's trained in guiding a patient and family through the journey from life to death. They're usually individuals who are working with a family when someone is close to death within a matter of days
Mhm.
or a week or so, to help with some of the symptoms that people experience as they're going through active dying.
Yeah,
When people are actively dying, they stop eating,
they do.
they stop drinking,
Hmm.
they get more sleepy.
Hmm.
Some people may even get more confused and agitated.
Yeah.
Um, those are some of the symptoms that we know as health providers will occur as people are actively dying, but a son or daughter witnessing it may get very anxious or
Yes.
afraid.
Yeah.
So death doulas are individuals that are there to help educate and to help provide care for someone as they're actively dying, and to sort of set the standard for what's normal and what's not normal, and try to give advice on different resources to help. When my mother was dying, uh, she had a lot of secretions that would get in the back of her throat.
Yeah.
And the hospice nurse, who was sort of like her death doula, helped us as a family to reposition her so that we would hear that sort of gurgling sound, which is a normal thing that happens as people are dying,
Yeah.
but was very distressing for my
Yes.
siblings as they saw that.
Yeah. And that is it. There are a variety of different things as people like yourself are in this specialization of palliative medicine and hospice, that we know different signs, right? And different things to be able to let family members know, no, this is normal. This is what you're going to hear. This is what you're going to experience. No, they're not in pain. We've given them something to mitigate that. And to be able to give them that comfort and understanding, because you've been in these positions before, you've seen it before, and you're there to be with them, either yourself or, again, like I said, a death doula, a chaplain, or someone else who's been part of the team that's been journeying with the family, to sit in those spaces that can be very tender, with a lot of emotion and feeling, obviously. Yeah.
Yes.
I am so excited about our community hearing this interview. I think that the information that you have provided, and the work that you do, and the advocacy that you have leaned into will extend the conversation even further than our time that's together. But I want to give you an opportunity, if there's anything that we've not covered to the extent that you would like to cover, or something else that you want to bring up. I want to invite you this time, if that's something else that you want to lift up to our community, that you want them to take away from this time that we spent together.
I think just going back to what you said in the beginning, change and justice. And I truly want my community to hear that hospice, as well as palliative medicine, truly is about giving life and giving support to you and your loved ones. It is not intended to take them away sooner. It is intended to allow them to have optimal life for the time that God intended.
Ah, there is no better way than to end our time together than with that. I want to say to our Tinderbox podcast community, I want to thank you, Dr. Williams, for your wisdom and your compassion and your advocacy in this tender and sacred work. I'm excited that you are part of the community, that you're out there as, again, a champion for our voices in research and in education. And I thank you for spending this time with us on the Tinderbox podcast to talk about what has been your life's work. And I'm going to call it a ministry. That's from my context. I'm going to offer that up. And so, Tinderbox podcast community, remember to pass this episode on to your loved ones to begin to have that sacred conversation about palliative medicine, hospice care, end of life questions. It's wonderful to have those conversations up front. It's going to take a lot of different conversations to have to get to some understanding of what you feel and what you desire for yourself and what you want your families to know, but also to come back and reference the nuggets of wisdom that Dr. Williams has brought to our listenership today. And so, with that, I always say stay ignited, stay kindled, and that's our tagline for the Tinderbox podcast because we ignite conversations. This has been one that has been ablaze, and I am excited about how far this conversation will go and the things that will be connected to it that will allow us to live well in our serious illnesses, but also in our end of life with respect and dignity and peace. With that, take care.
Thank you. Thank you for this platform and all the education that you provide in advocacy.
Thank you.